Good day, all, and welcome to the Teledyne Pulse podcast, your Rural Health Matters resource. Hear from your colleagues and industry experts on rural health issues and innovative care models that make a difference for rural hospitals, providers, and communities.
Well, Shane, one of the things I hear you talk about a lot is we don't want our services to be a financial boat anchor for any facility. And positive ROI and sustainability is kind of one of our hallmarks. We have a guest today that has some thoughts about ROI and excited to talk about this.
Yeah, I'm excited. This is going to be a great podcast, Andy. I'm always shocked when people agree to come on to these things. In fact, somebody asked me the other day, who really would even come on and talk to you in a podcast, which is, we won't talk how much we got to pay these people. But nonetheless, I'm excited today to bring Dr. Judd Hollander on our podcast today to talk about an article that he's involved in publishing here recently through the Virtual Care Symposium in 2024 called Selling the Return on Investment for Digital Health, and which was published in Telemedicine reports here late last year. And the return on investment is something that we do a lot of discussions with hospitals and hospital systems on when it comes to their digital health strategy overall and what that looks like. And I'm excited today to have Dr. Hollander on with us and an opportunity to kind of talk through some of the high level points in this article and get his perspective, which is different. In some instances, he's going to bring a different view than what I have from a different system and a large system, nonetheless, up in the Northeast. And looking forward to the conversation. So, Dr. Hollander, excited to have you on the podcast. And how about you introduce yourself and a little bit about Thomas Jefferson?
Thanks, Shane. Excited to be here. I'll talk more about Jefferson because that's my telehealth experience up front, and then I'll give my background. So Jefferson, when I got there in 2014, 2015, was a 3-hospital system with about $1 billion in revenue. Jefferson today has 60,000 employees, 32 hospitals, 700 care sites. And I've had I'll say the pleasure of rolling out telemedicine first in a 3-hospital system. And as we've gradually gotten to expand, I got to roll it out in another system and another system and another system. And each one had maybe more challenges than learnings, but they've built on each other. So I've had that experience, which is really kind of interesting and shaped the way I think about it over a decade. But I came into Jefferson with a background. I'm board certified and trained in internal medicine and emergency medicine, was a practicing physician that led a large clinical research program, which in my mind was, fun, creating new knowledge and new ways to go forward, largely related to acute care diagnostics, which actually ties into telemedicine because that is an acute care diagnostic in part. And at some point in my life, I realized, wow, if I could do numbers in a spreadsheet for research, if you put a dollar sign in front of them, it might actually have more value to the health system. And so I went back to Wharton and took some of the executive programs, did not get an MBA, took the courses that my mentors and, in fact, my son, who had been through Wharton, recommended would be best suited for making the transition from spreadsheets in research to spreadsheets in business. And gradually migrated from a clinical research director at the University of Pennsylvania to running a chain of urgent care centers telemedicine program and looking at some joint ventures in innovation at Jefferson, and have grown with the enterprise over the last decade.
Yeah, that's fantastic. That's some impressive growth. And what's more impressive though, Dr. Hollander, is, coming into that mix, and I can't imagine, a university-based system. There's no bureaucracy there, is there?
None, absolutely none. Well, actually, so it's funny you say that because of course there is. But when I came in, at least in my telemedicine reporting strategy, it was direct to the CEO, which eliminated a lot of the bureaucracy because nobody, including me, actually knew what authority I had and what I was able to do on my own. But when I had a question, it was direct to the top. So it was really helpful. It didn't mean it didn't need legal compliance, regulatory input, et cetera. But it did cut through the red tape quite a bit.
Yeah, that's interesting. It's almost a similar concept to where we were 11, 12 years ago in the fact that, when we were trying to roll this out and build this, nobody knew what we were doing. In fact, we didn't know what we were doing. And so maybe if nobody knows what they're doing, then you just cut through the tape and go to the top because nobody knows what they're doing. We're going to figure this out somehow. But now, unfortunately, today, now everybody is pretty well versed, at least on what it means. And now there's all kinds of cooks in the kitchen, and maybe the bureaucracy is a little bit more than it was 11, 12 years ago.
Yeah, when I first started, I had to explain to people what I did for a living. And I don't have to do that anymore. People understand what telemedicine is now.
For sure.
Well, the other advantage, I should give a shout out to Robert Rosenwasser, who's our chair of neurosurgery, who 4 or 5 years before I got there, did a neurostroke network and expanded stroke capability into 30 hospitals in the region. So people knew what telemedicine was. And there was somebody that was a leader in the field nationally and internationally already. We were doing different things than he was doing, but he did actually pave the way.
Yeah, that's excellent. That's excellent. Well, that sounds great. Well, excited to get into some of the discussion here today about the article, the return on investment for digital health, and ROI. When it comes to these solutions, oftentimes is a little bit elusive, and I think you have several great components throughout this article and this research panel that you put together on these fronts. So I'd just like to highlight a little bit of some of the highlight points here within the article. I think what we'll start with is in terms of return on investment. When you think about, I know you and I've talked about some of your return on investment discussions you've had with leadership over the years, and how do you go about doing that? And so maybe you could shed a little light on, based on your experience in discussing return on investment from a health system perspective, what are some of the key points that you're looking for and have come up with over the last few years?
So I think the biggest key point is you need to understand how the decision makers think. And at different times, it's different things. So to some health system leadership, it is all about access. And if you get me new patients, I'm going to believe that I have downstream revenue. To other health system leaders on the opposite side of the bell curve, it is about, if I give you $100,000 for this, where are you cutting $100,000 on day one? So I know you're not like everybody else telling me you'll save money, but you actually cut nothing and you just increased expenses. And so really getting in the headset of the decision makers is most important. And, I've worked with decision makers on both sides. It's obviously easier if you don't have to prove you have ROI, but it's obviously better for the health system if you do have to prove you have ROI.
Mm-hmm. No, for sure. And when you think about that, and that kind of ties into some of your other comments of whether you're, what are we trying to solve? What are the issues at hand in terms of, a lot of organizations that we've worked with have a similar mindset, and I agree 100% with. Is it a visionary CEO model or is it a CFO model in terms of who you're dealing with?
Very fair.
That's who. So, and then you got to pivot to which direction you're going to go in terms of that ROI discussion. But obviously, we don't want to build them in silos, and you point that out in the article. And then you also point out from more of an organizational strategy perspective, and what are we trying to solve and solutions you're trying to solve, or that you can bring to the table to help solve challenges or needs within the organization. So can you maybe walk through some of your examples of how you have sort of identified challenges or helped Thomas Jefferson identify some of those challenges and needs, and how maybe some of these solutions could then address those challenges and needs?
I'll start with how you don't do it. You don't do it by fielding emails from friends of people you work with that have just started a company that are trying to begin, right? You don't do it by doing free pilots for companies, because a pilot is never free, because a free pilot still costs you $100,000 in labor and resources to do EMR integration. So the workflows are successful.
Mm-hmm.
And I think with that whatever you do, there are a lot of competing resources around the enterprise. And one of those competing resources can't be doctors being tortured or nurses being tortured by implementing a new technology that totally changes their workflow to make it more complicated. So a lot of it is change management. But the way you get people to buy into things is you solve their problems. So, and not everybody perceives the same problem as a problem. So I'll give you two examples from the past year. One is, if you have cancer, how long do you want to wait to see an oncologist? It's not 3 weeks, which is what it takes nationally. So we created a same day, next day oncology program where literally we hired generalist APCs that will see people this afternoon if you call in the morning, or tomorrow. And we average a 1.07 days from the initial call to you have your appointment.
That's
And,
incredible.
and then we changed the workflows because we hired people that would be tapped into the system. So if when they got to, what do I do with this lung nodule, they had speed dial to the pulmonary oncologist to figure out what the next step is. So while they're on the phone or the video call, they can get the answer to the question, so they don't need to send this person to somebody else for further advice and move them into the system. And what we've done in that, and we've now added it to the emergency department. So you find a new mass in the, on an abdominal CT, you can get that person in to be seen later today, rather than have to admit them to the hospital, make them linger over the weekend, in order to be sure they get follow-up care. So that's one great new program. Solve the problem for patients, solve the problem for the system. And we've shown we get people answers and decrease their anxiety faster. I got to tell you, the emails we get from these patients are like the best emails ever.
Yeah,
right? It's not "you saw me too fast," to put it that way. And they get plugged in for chemo, or they get plugged in for surgery, and they get plugged in with the specialist oncologist much faster. That's one.
Yeah.
The second one, which is actually kind of my favorite one, I don't want to downplay the first, is that we opened a new $750 million building called the Honickman Center. And when they were designing the building, they either had an option to make more patient rooms or more rooms for people to check out at the front desk. And they basically said, can you make us a checkout system so we could do this virtually and we don't need people taking up space where we could have exam rooms? So people on my team designed what we now call virtual checkout. And in every room in the center, there's a whiteboard, effectively a large screen TV, that has things for patients to do while they're waiting for the doc to come in the room. It might be look at artwork. It might be select your music. It might be learn more about your doctor or your condition. And they can do that on a touch screen. But when we're done with the visit, the doctor hits a button on the screen, enabling the patient, when they're dressed, to open up the camera and hit the button, and they get a virtual checkout. So now, from the privacy of the same room they've been seen in, they could schedule their checkout. They're no longer standing in line saying, hey, my doctor said I should get STD testing, where the whole waiting room could hear
Right.
And it turns out that when you look at ROI on this program, we can't put dollars and cents on it yet, but we know that the longer it takes you to make an appointment, the further out your appointment will be. And we know the further out your appointment is, the more likely you are a no-show or a cancellation, and you find somebody to see you sooner. And we've reduced the average time to make all appointments from 18 days to less than 2 days, which will translate into fewer no-shows, more follow-up, more of the basic gap closure procedures, mammography, colonoscopy, because the patients go home with a scheduled appointment rather than go home with a phone number to call.
Yeah.
And so, those are two cool things where we solved some real problems and made it better for patients.
That's spectacular. That's spectacular, and kudos on both of those programs. And golly, those are actually both amazing in terms of the response you're getting on both of those. But to your point, it gets back to identifying a problem and taking a step back and just trying to think about how can we solve for this, or just saying again, and kudos to just thinking outside the box in terms of the routine. How do you check out of an organization, or how do you enhance that process? It's fantastic. So lots of opportunities there, but half the battle is getting to what are we going to solve for, rather than, and oftentimes, early, especially several years ago, it was, a CIO would be tasked with, hey, go find some technology that's going to help us solve this. And unfortunately, what works best anyway is if you can work with the organization to really tee up what are our priority challenges, and then what kind of solution can we build around that to solve it, as
Yeah.
opposed to.
And that's a really critical point, because I think in most organizations, the telemedicine program, digital health, virtual care, whatever you want to call it, rolls up to the CIO. But everybody would say that IT is a solution. IT is not a strategy.
Exactly.
And so I sit within Jefferson Medical Group, which is our physician group,
Mm-hmm.
to help hear what the strategies are at the higher level, and then be thinking about what problems are coming down the road and how can we solve them. Obviously, I don't build the technology myself, but I have a team of people that does include our CMIO and CNIO that can go out and say what technologies exist, what can we implement fast. And then I don't run most of the technologies, and I don't run most of the programs. Telemedicine done by cardiology is run by cardiology. Neurostrokes run by the neurostroke people. But we help resource the care in a manner that will get us to the highest value.
Mm-hmm. Yeah, perfect. Yeah, I can't agree more. So I'm going to pivot back to one of your original comments here when you started off with. I'm going to tell you what not to do, and what not to do is field an email from an individual saying, "I just started a company," and I tell you, I think we'd be a great fit for Judd and his team at Thomas Jefferson. I mean, you can't believe what we're going to do for you. But you in the article, you reference a comment along the lines of, hospitals and health systems they're looking for partners. They're not really looking for vendors. They're not looking for fly by night organizations, or an organization or potentially a software company that's looking for an early exit or an exit strategy. They're looking for somebody who perhaps has been there, is there, and will be there as a partner moving forward. What are your thoughts around that?
So I think you summed it up pretty good, is that when you come to me and your slide deck starts, and I had this experience yesterday, literally, and your slide deck starts with, we have a product for diabetes. Let me tell you about who we are and how many exit we had. It's basically your pitch deck to the private equity or venture capitalist. And then you spend 5 slides telling me that diabetes is bad.
Yeah.
Like, you've lost me. I have no interest in you. You
Yeah.
don't understand my needs. I have no time. I want to know, what do you do? Why do you do it better than anybody else? And what's my ROI going to be on doing it?
Yeah.
And so some people fail at the pitch level with that, and they're out because they clearly don't understand the industry and what we need.
Right.
What we want is kind of people, I'm going to say, on the 3 extremes, if such a thing exists. We want mature companies that need to get more mature, that need help, because we would rather do a deal as a development partner than a pure vendor relationship.
Mm-hmm.
And so we would like to work off pricing discounts. In fact, we'd like to net to zero. And I've sat in the room with companies that are mature, some of which are public, and said, can't pay you for that, but I could give you this. You just decide if it's worth it.
Right.
And sometimes they do and sometimes they don't. And both of those are okay. So I want a company that's mature enough, but we could help take forward, and that they're not looking for an exit. On the other side, if there's a startup that's solving a problem for me that nobody else can solve, I want equity in that company. Then you could do your quick exit.
Right.
But then we are a true development deal. We
Right.
can put money into the company. We could get equity. We get royalties. But what we don't want to do is, quote, the for free pilot, because it's not for free. You're going to spit your company out and get tons of money, and we're going to have done a pilot. And my analogy to that, and I think I talk about this in that article, is my past research career was a lot of biomarker and pharmaceutical trials. And every one of those companies got money from their raises or their backers to do clinical trials to prove it works. And every one of those companies paid me fair market value to do that clinical trial for me, the nurses, the techs, the lab assistants, and everybody else.
Right.
What digital health and virtual care companies don't want to do is pay for clinical trials. They want to give it to you for free, which again is not free. So we will do early stage things, if it's aligned with our strategy, solves a problem we can't get solved otherwise, and there's a potential upside for us that makes it sense to do it. Or we could do it through research if you just want to pay us to do it through research and somebody's interested in that area. And then at the other end of the spectrum, there are some companies that are reasonably far developed that are unlikely to want to give Jefferson a piece of the pie. So the question is, do they solve our problem in a way that nobody else can? And can they create a model that truly has a positive ROI so we could go forward with that? Any one of those three things is fine and preferred over generally just buying a product.
Right. Well, and it gets back to the point of just a partner, and this is hard. This stuff is complex. It's hard. You're dealing with doctors, you're dealing with nurses, you're dealing with patients, complex patients, bureaucracies, technologies. I mean, I don't know how many more complex things we can throw in the mix. That's a lot.
Yeah.
That's a lot to ingest, and somehow, assimilate that in a productive mechanism that actually solves a problem and does produce an ROI. And I like one of your comments in the article, kind of spinning off.
Only one? You only like one of the comments?
Well, listen, I liked a lot of the comments, Judd. I mean, come on, okay. I did. I liked a lot of them. But the venture capitalist perspective, having a health system investing and buying in the service impacts how the business is being funded. And having a health system eating their own dog chow is vital for credibility. And I think what that really tells me, at least as I read that, is the onus on the organizations is part of a partnership, right? To work together and help each other and build something great. Is that kind of your perspective on that?
Yeah, well, first, that's a great line, but I have to give that to one of my co-authors. That didn't come out of my mouth, but I share the perspective that at the end of the day, a company wants to prove their product works, and I did this in my research life as well. Somebody would present something about how great this is, and my question was always when I was moderating, well, what are you doing with that now that the research is over? And 90% of the time, they're not doing it.
Right.
And it was just fun and games research project.
Right.
And so I think that, if I owned a company, and you do, you would want people to use the product and not just try it and disband it. So you have to develop a product that is good enough that when people try it, they want to embrace it. And in the absence of that, to say, hey, Jefferson tried our product and they really liked it. And someone says, is Jefferson using it? And the answer is no.
Right.
Not really going to help you grow a company.
Yeah, it does. It's tough. That makes it tough when the reference is, well, it was great. We really help with that, but we don't use it.
Yeah.
makes it kind of difficult on that front. So I completely agree. One of the things, in terms of the digital strategy in some organizations, I'll get a phone call that would say, hey, can you come in and help us? We'd like to discuss and build a digital strategy. And I always try to steer it in a different direction. Let's not maybe go down that route. Let's maybe back up and let's try and figure out what our challenges and needs are to try and solve those. But one of the things that we're working on is, and you and I've talked a little bit about this in terms of the more of a system-wide approach where we're really trying to, with all the disparity in the technologies today, really working to enhance the platform where we can deliver a lot of different virtual solutions through a single platform across an entire organization or entire system or network of systems that really integrates clinical services, ancillary services. I'm not going to go through all those, but there's essentially endless possibilities, right? And how you integrate that. And I'm interested in your thoughts as you've walked through this and your experience with Thomas Jefferson over the last 10, 12 years and through, in the development of this article and the return on investment, your perspective on as our initiative in terms of trying to avoid, again, I'm a big non-silo guy. I hate building things in silos. It just doesn't work. And so for us, of course, we work with a lot of disparate organizations across our 100 plus hospitals and systems. But for us, really trying to build a system that is for almost a tech stacking type mechanism, but really conducive to many different services through many different organizations, disparate partners through the same platform and system to ease, if you will, the tech burden and the frustration a lot of the organizations have with dealing with multiple vendors, multiple tech companies, multiple softwares, and multiple workflows, and the list goes on. So what are your thoughts moving forward on that type of thought process and how you look at it from Thomas Jefferson's perspective?
So I'll tell you the way I look at it from my own perspective, but I think it's shared largely within Jefferson. You want tech stack consolidation. You want one product that could do everything. And you have to be willing to compromise, because someone could develop a point solution that's best of breed. And in fact, we're switching, in one area from one company to another company. I won't say the area or the companies. And, a lot of people are like, well, I don't like this. And why don't you like it? It comes down to, well, I'm used to doing this and now I have to do that.
Mhm.
And it's perceived as, right, the first thing you hear is, well, this new product stinks. And then when you get down to it, it's like, well, I liked it that it was a right click and now it's a left click and I can't remember to do that.
Yeah.
And so the change management is very difficult. It's kind of like, health systems know this. Most or many health systems are on Epic. They were on something else first. And the first thing you hear about Epic is, oh my God, it's horrible. But when you see the power of being on one system, most people end up embracing it. Certainly
Right.
most people in the leadership position. It's the same with telemedicine technology, but you need to understand clearly that telemedicine / virtual care technology is not designed to be a documentation system.
Right.
And so you could take electronic health records that then add on something that can do virtual care. And yeah, it could do virtual care. And if you want to stay in one system for everything, you could do that. But they're a documentation and billing system. So that virtual care is never going to be as robust as people that are wholly tied to virtual care. Likewise, a virtual care platform is not going to have the same documentation
Right.
capabilities
Completely
of an
agree.
electronic health record. So change management gets hard, and deciding when you can all be on a unified platform and when you need to have point solutions is difficult. That said, what we've tried to do is consolidate. And I mentioned cardiology before. We don't do telecardiology and telestroke and telepulmonary and telederm. We break down telemedicine into a couple different things. There's asynchronous, right? Text message, there's chatbots, whatever. There's synchronous, which is basically audio, video, face to face. Then within the synchronous category, you're either doing it between two providers or two staff, or you're doing it between a patient and a staff or provider. That's it.
Mhm.
And then I know that if you want to do telemedicine into hospital room number 7 with a pharmacist or a chaplain or a nutritionist or a doctor, it's the same exact technology.
Yep.
And we know how to do that.
Yep.
So we like technology that could allow us to optimize that schema. And then when we want to, we can now add consults on Saturday or consults at 3 a.m. And particularly in our neck of the woods and where you're based out of, you don't have to drive hospital to hospital to do the consultation. The case managers don't have to go hospital to hospital. They literally can pop into a room and get it taken care of. So the consolidation of a virtual care platform that allows multiple people to use the same platform depending on their role, I believe is essential to going forward.
Yeah, can't agree more. So almost, but we're totally aligned on that front. I'm gonna have to write that down. I'm not sure.
I think you got it recorded, Shane.
We do got to record it. Holy moly! No, gosh, I can't agree more. And I think what you've accomplished at Thomas Jefferson since you've been there is amazing. There's a lot of fantastic things that you're doing there, and the two problems that you solved that you were shared with us today on the podcast are fantastic, and it just shows you, you have to have the right individuals at the table in the right time to be able to come up with those types of thoughts and processes, because I tell you, there's a lot of organizations that sit around the table wanting to know, and all they're going to spend time on is arguing over room size and who gets more rooms than the other. Not, is there a different solution? And without the right individuals at the table, you're never going to hear that potential solution, right?
Right.
So kudos, and it's fantastic that you've been such a valuable asset to that university and health system over the years, and the growth's been exponential. So can't thank you enough, Judd, for stopping by today on our podcast. And if there's anything that I learned today was just the ROI and the discussions around ROI. There's a lot of synergies in terms of how we look at ROI and how Dr. Hollander and his team looks at ROI, and a lot of similarities in terms of discussions we've had over the years.
Absolutely.
But any parting thoughts, Dr. Hollander, before we end today?
So I think I will add one that I don't think I've ever vocalized out loud, but we try and do, which is ROI is an elevator pitch. If you can't simplify it, like when I go to the C-suite for us, I get 3 slides. You're not allowed to walk in there with more than 5 slides. One's a title slide. You know, so it's really like slide 1's what problem are you trying to solve? Slide 2 is how are you going to solve it? You know, and what other things did you consider? And slide 3 is what's the ROI in spreadsheet format?
Yeah.
And if you can't reduce it to that, you're not going to sell it. These guys are sitting in a 2-hour meeting hearing 20 different pitches.
Yeah.
If it's not not concrete, it's not going to work. And so I think, and again, you can only condense what would be 30 slides to 3 or 4 slides if you understand what the people in charge need to hear.
Exactly.
So you need to know how they think.
Yeah.
So I think that's it. And one thing we haven't addressed, which I do like to address, is when I started the telemedicine program, I looked at it differently, right? I had a strategy guy that wanted to really be leaders in vision. And so we were able to, spend a little more money, and we didn't really know how things were going to work. And it was pre-COVID, et cetera, et cetera. But at that time, I sold a lot of our basic telemedicine program as we're the 3rd floor of the hospital. Like, you know what you don't have if you don't have a 3rd floor of the hospital? You don't have a 4th, 5th, 6th, and 7th floor of the hospital. And so nobody says, what's the ROI in room 312? And nobody says, what's the ROI on your EMR? It's a necessary infrastructure. You have that building or that technology to take care of patients in an integrated fashion. So as much as we've talked about ROI, I do need to come back to there's some basic infrastructure you need to have. You need the 3rd floor. You need the virtual care floor. Otherwise, you don't have a health system.
Can't agree more.
That's a great point.
And it kind of gets back to, as we look at this, it's really over time, many of our clients, we have such a high retention rate, 95+% over the last 11 years that it's really anymore. In fact, I did a presentation with the CEO here not that long ago, and his comment was, really, we don't even view it as virtual care anymore. It's just care.
Right.
It's just part of what we do. It's how we do it. It's integrated into the fabric of how we deliver care. So it goes exactly to your point. And unfortunately, especially when you're dealing with more of the CFO side of that pendulum versus the visionary side, sometimes it's hard to get over that hump to get the fabric built.
So I think, what we've done is just leverage the programs that have bigger ROI first.
Right.
So we talked about this earlier, and I think it's in that article. Telesitting has a really easy to understand ROI.
Right.
So you can do telesitting, and if you have one piece of technology that could do telesitting and e-nursing or virtual nursing and provide a consultation, those other programs that probably don't have an individual ROI can all be funded off the heels of the telesit ROI.
Yep.
So it's having a smart approach. And as you coalesce technology, you can do that. But if you needed a different technology to do virtual nursing than you need for telesitting, you're kind of screwed.
Absolutely. And that's why in the platform where we have our virtual nursing repository and sitting and all the other physician services and all the ancillary services is all funneled through the exact same system, because to your point, it's very hard to cross subsidize boat anchor programs that are necessary, but yet have a strong case to produce in terms of ROI. It's hard to subsidize those if you have to stack another piece of expensive technology on top of it. I can't agree more. So you're spot on for certain. So yeah, without a doubt, more great comments coming from Dr. Hollander there. Anything else, Andy? Any other questions from your end?
Just appreciate the review of ROI and some of those easy to prove ones like sitting and just your approach to, talking to C-suite.
Yeah, I think, again, it was great to hear more about all the great work you're doing over there, Thomas Jefferson, over the last 10 plus years, and excited to continue the fight, if you will, in terms of moving this forward and helping get access to care across the country. So, Judd, I can't thank you enough for your time today. Really appreciate you hopping on with us.
Good. Happy to be here, guys. And impressive the work you've done over the last decade or two to grow out and cater to 1 million hospitals.
Yeah. Well, I appreciate that. It's been a lot of work for sure, but it's been great. I got to tell you, if I'm asked this all the time, what's attributed to such a high retention rate and the success over the last 10 years? I said, this is a two-way street, and you actually point this out in the article, Judd, in terms of, and how you word it is essentially you have to find ways to get docs to buy in and nurses to buy in and people to use it, right? Because if they don't use it, nobody's going to win in this. And this is a two-way street. We could provide all the fancy technology and all the providers support it. And if nobody wants to use it or we can't help them use it, it's you're not doing any good, right? Yep. So augmenting it with things like virtual nursing to help a nursing workforce that's maybe lacking experience or competence is a big deal. And so we have to find creative ways to augment that in order to facilitate care. But you're right. If people aren't going to use it and they don't find a way to get that provider buy-in, at least over time, it's going to be a challenge for sure. So fantastic article. I enjoyed reading it, and thank you so much for agreeing to come on the podcast and talk a little bit more about that. Appreciate it.
Pleasure chatting, guys.
We would like to thank you for joining us today. Our promise to you, the listener, you will be inspired or at a minimum find value in the information shared in this podcast. Please offer a comment or offer feedback so that we can improve this podcast and better meet your needs. Please remember to share this podcast with others that you feel may get value out of this by listening. And it's always helpful to subscribe to the podcast channel so that you're aware of future episodes and releases. In addition, if there is a rural health topic you would like to have covered on this podcast, please leave us a comment, or you can send an email to pulse@teledynehealth.com. That's pulse@TELEDIGMhealth.com. For more information or general inquiries, please visit teledynehealth.com.